Can we trust a normal ABI in diabetes?
Now contrast this with ischemic diabetic foot disease, which boards may present very differently. These patients tend to have cold feet, diminished or absent pulses, and painful ulcers. Ulcers are often located at the tips of the toes or along the lateral margins of the foot, rather than at plantar pressure points. A distal toe ulcer with necrotic tissue should raise concern for critical limb ischemia due to peripheral arterial disease. In this setting, the correct next step is vascular assessment rather than aggressive debridement. This is where the ankle brachial index becomes a high-yield testing concept. A low ankle brachial index supports peripheral arterial disease. However, boards can introduce an important pitfall in patients with long-standing diabetes or chronic kidney disease. These patients often have medial arterial calcification, which makes vessels non-compressible. As a result, the ankle brachial index may appear normal or even elevated despite significant ischemia. The correct next step is distal perfusion testing. Boards can test toe brachial index because toe arteries are less affected by medial calcification. This test is recommended when the ankle brachial index is elevated or discordant with the clinical picture. Absolute toe pressures can also be used. Toe pressures below approximately 30 millimeters of mercury or below 40 millimeters in patients with diabetes predict poor wound healing. Transcutaneous oxygen pressure is another option. Values below roughly 25 to 30 millimeters of mercury suggest critical limb ischemia and impaired healing potential. Guidelines align on this approach. The board-relevant takeaway is this: a non-healing ulcer with a normal ankle brachial index in a patient with diabetes or end-stage kidney disease should make you distrust the ankle brachial index.
Visit www.easyendoprep.com and start your free trial today.